like to have Dr. Shumpa Bakura up to the stage. You're already there to introduce the next section on vaccine safety.
Hi, good afternoon. I'm going to reintroduce the topic of the febrile seizure signal in 2010-2011 following trivalent inactivated influenza vaccine and 13-valent pneumococcal conjugate vaccine as a lead-in to our two main presentations. But first, some information on febrile seizures. So a febrile seizure is a seizure accompanied by fever without central nervous system infection that occurs in infants and children 6 months through 60 months of age. Febrile seizures are fairly common during childhood. About 2 to 5% of young children will have at least one febrile seizure. Febrile seizures can happen with any condition that causes a fever, including typical childhood illnesses, many of which can be prevented by vaccination. Rarely, febrile seizures can occur after vaccination. Nearly all children who have a febrile seizure recover quickly and are healthy afterward with no lasting effects. However, febrile seizures often result in a visit to an emergency room and can be frightening for parents and caregivers. So this table includes the post-licensure vaccine safety monitoring infrastructures that are going to be presented today, data from these infrastructures. You heard about VAERS this morning from Dr. Cano. The Vaccine Safety Datalink is a CDC system, uses a large link database for active surveillance and research. The Clinical Immunization Safety Assessment Project is a collaboration between CDC and academic centers, and they conduct clinical research. And the Post-Licensure Rapid Immunization Safety Monitoring System is an FDA system. It's also a large link database system used for active surveillance and research. So the definition of a signal in pharmacovigilance, because I'm going to use that term a lot, is reported information on a possible causal relationship between an adverse event and a drug, the relationship being unknown, previously unknown, or incompletely documented. Usually more than a single report is required to generate a signal, depending on the seriousness of the event and the quality of the information, and that's from WHO. So to recap background and key events, in 2010-2011, there was a VAERS data mining signal for flu zone and febrile seizures. The clinically relevant age group was in children 6 to 23 months old. And it's important to note that flu zone is the only TIV that's approved for use in children 6 to 23 months old. At the same time, we were conducting rapid cycle analysis in the Vaccine Safety Datalink. Just to remind you, rapid cycle analysis is weekly, near real-time surveillance that we do during the influenza season and for other vaccines in the Vaccine Safety Datalink. And we also detected a signal for febrile seizures following TIV in children 6 to 59 months old. At the same time in VSD, we were doing surveillance for PCV13, so we were able to do an epidemiologic study looking at TIV and PCV13 in febrile seizures. And the key finding from that study was that the attributable risk for concomitant TIV plus PCV13 peaked at 16 months with 45 additional febrile seizures per 100,000 children vaccinated. The following season, 2011-2012, the formulation did not change. So the same TIV formulation in 2011-2012 as 2010-2011. The VSD rapid cycle analysis signal for TIV persisted. And during that season, we also conducted a CISA TIV PCV13 fever study. And the key finding from that study was that children 6 to 23 months old who received TIV and PCV13 together at the same visit were about 3 times as likely to have fever on days 0 to 1, that's the day of vaccination to the day after, compared with children who received TIV or PCV13 without the other product. Then in 2012 and 2013, there was a change in the TIV formulation, and also 2013-2014 was a different formulation than 2010-2011, and there was no VSD rapid cycle analysis signal for TIV. So this just illustrates this graphically really, but I want to, moving from left to right, from the 2010-2011 season to the current season. So in the southern hemisphere, there was a signal for febrile seizures following a CSL, trivalent inactivated influenza vaccine in young children. And the Southern Hemisphere influenza season precedes the U.S. influenza season. And because of this finding in Australia, CDC and FDA conducted enhanced monitoring in 2010, 2011 for febrile seizures. So we routinely conduct monitoring for febrile seizures every year during the influenza season. And for that season in particular, because of what we observed in Australia, we were reviewing every seizure report that came into VAERS, and we also were looking at other risk intervals in our VSD rapid cycle analysis, namely a 0 to 1 day risk interval in addition to a 0 to 7 day risk interval. So this is a graph which is adapted from the original VSD study using the 2010-2011 data. And you can see from here on the bottom, you have in the green TIV without concomitant PCV13, and then the dotted line PCV13 without concomitant TIV. And you can see a small increased risk for febrile seizures peaking around 16 months of age. However, when TIV and PCV13 were given together, you see that noticeably large peak there occurring at 16 months of age in febrile seizures, and that attributable risk was 45 additional febrile seizures per 100,000 children vaccinated with TIV and PCV13 together. So CDC, FDA, and ACIP reviewed the data during the 2010-2011 season, and after evaluating all the information, CDC determined that no changes in the childhood immunization schedule were necessary, and we posted this information on the CDC website. We also updated the vaccine information statement for TIV for the following season to include this language: young children who get inactivated flu vaccine and pneumococcal vaccine at the same time may be at increased risk for seizures caused by fever. So there were some additional questions that we had after the 2010-2011 season. Namely, did other vaccines besides TIV and PCV13 play any role? Was there something unusual about the 2010-2011 influenza vaccine that resulted in the increase for febrile seizures in young children? And what did the data prior to the 2010-2011 influenza season show? So now we're going to hear two presentations: Seizures following multiple vaccines, a Vaccine Safety Datalink study from Dr. Jonathan Duffy, and assessment of febrile seizures after trivalent influenza vaccines during the 2010-2011 influenza season in the post-licensure rapid immunization monitoring system by Dr. Allison Kwai from Harvard.
Hello. So as Tom said, the definition of febrile seizures is specific to children in the ages of 6 to 60 months who do not have an intracranial infection, metabolic disturbance, or history of afebrile seizures. So prior to the 2010-11 influenza season, other vaccines had been associated with an increased risk of febrile seizure, and they're listed on this slide. So the whole cell pertussis vaccine, and the measles, mumps, rubella vaccine, and the MMRV vaccine. And as you can see, the risk interval for each vaccine is different. We're talking about a transient risk that occurs over a several-day period in the post-vaccination. And for MMR and MMRV being live vaccines, the risk interval is related to the incubation period of the live virus. And then in 2010-11, this new finding for the TIV and the PCV13 were signaled. So the study I'm talking about now is in response and developed in response to those findings in 2010-11. So in addition to what Tom said, the interest in PCV13 in 2010 was really because that vaccine was new in that year, and so that's why there was a particular interest or focus in that vaccine at that time. And then subsequent to then, there's also been the VSD PCV13 RCA, which is concluded, which did not find any increased risk of febrile seizure when comparing PCV13 to PCV7. So the objective of my current study is to assess whether vaccines other than PCV13 given concomitantly with TIV affect the risk of febrile seizure. So this is a Vaccine Safety Datalink study, and the VSD is a collaboration between CDC and several integrated healthcare organizations. It has a combined annual population of over 9 million people, approximately 3% of the US population. So for this study, 10 different VSD sites contributed data to the study, so you can see that they're geographically dispersed across the United States and tend to represent sort of more closed model health plans that have good data capture and well-defined populations. So the methods we used to find febrile seizure cases, we looked for any medical visit with an ICD-9 diagnosis code of 780.3, which is convulsion or febrile seizure, occurring specifically in the ED or inpatient settings. And it had to be the first occurrence of the code in 42 days to find incident events and exclude any follow-up visits for previous events. So we then confirmed cases by reviewing medical records to confirm the diagnosis of febrile seizure and the time of onset. So we focused on the study period of 2006 through 2011. And we focused on ages 6 through 23 months because they're the highest risk for febrile seizure at baseline, and then those are also ages at which vaccines are in the recommended schedule. So our febrile seizure case definition for this study is a clinician diagnosis of seizure with fever measured or reported and excluding patients with intracranial infection, metabolic disturbance, or history of afebrile seizures. So the type of analysis we used is called a self-controlled risk interval method. So we use a conditional Poisson regression model, and we're modeling the incidence rate ratio. So we're comparing the incidence of febrile seizure in the 0 to 1 days post-vaccination, which we refer to as the risk interval, and we are comparing that to the incidence rate during the days 14 to 20 following vaccination, which we refer to as the comparison interval. So again, with the thought being that the 0 to 1 days are the applicable biologically plausible risk period for febrile seizures following inactivated vaccines, and that the 14 to 20 day period represents a baseline risk in which the vaccination plays no role in the incidence of febrile seizure. So we then also estimated the attributed risk, and this was simply by taking the relative risk, multiplying it by the background incidence rate in the VSD population per person day, and then taking into account the fact that we're looking at a 2-day risk interval. So again, the attributed risk is just an extrapolation or translation of the relative risk. So now into the results, I want to show you some background on the VSD population. So looking at the VSD population, the background rate of seizures, regardless of vaccination, as we can see, as expected, varies by time. So shown here on the graph between ages 6 and 60 months, we can see the peak incidence is at about age 16 months old. And at the peak in incidence, it's almost 5 seizures per 100,000 persons per day. So then we're also interested in vaccine combinations in this study. And so when you look at, again, the entire VSD population, looking at these age groups, the number of unique vaccine combinations received by children in practice is very large, over 2,000 different combinations when you consider unique products and unique formulations as separate types of vaccination. So now when we look at how vaccines are given to children in this age group in the VSD, you can see in the first column all the different vaccines listed. In the second column, the total doses given within the VSD during this time period. And in the third column, we're looking at the number of doses that were actually given alone. That is to say, given on a day in which no other vaccine was received at the same time. And so when we look in the fourth column, we see the percent given alone as expected for most vaccines is very low because vaccines are often given at the same time with each other. So one exception to this is the inactivated influenza vaccine, which about 50% of the time in the VSD population is given by itself, again, on a day when no other vaccine is received. So looking at this more closely, on the next slide, when we look at this by flu season during the study, we see this has been fairly consistent over these years that we examined, that about 50% of TIV vaccine doses in this age group were given alone. So now this is just a preliminary analysis showing that if we look at that self-controlled risk interval analysis of TIV by flu season to get an initial sense of whether there were differences in flu vaccine across seasons, we can see that in years prior to 2010-11, when we stratified to just those flu vaccine doses given alone, we're not seeing an indication of increased risk of febrile seizure. And in 2010-11, looks like there could be something different that year. And then in the far right column, when we look at people who receive TIV at the same time as another vaccine, we do see higher relative risks. So this is what we want to examine further. So now moving on to our chart-confirmed analysis. So our case findings started with over 1.9 million vaccination visits in our study period for people in our focus age group. And then among these people, we identified 596 people who had a medical visit for a convulsion during our pre-specified post-vaccination intervals. We then took a random sample of these, and then among the charts that were available, 428 were available for review. So then when reviewing these charts, we see that some of these coded cases did not represent a new seizure event. In some of these, the clinician was not sure if it was a seizure or not. They said it was possibly a seizure. Some of these events represented people that did have a seizure, but it was a non-febrile seizure. And then in 27 of these cases, there was no fever status documented, so we don't know if it's a febrile seizure or not, and those cases had to be excluded. We then also had to exclude several cases for reasons related to when it occurred in relation to vaccination. For example, 2 people were vaccinated after they had a seizure. And then we had some people where the time of onset was different than what had been recorded in the administrative data. So in the end, we have 333 chart-confirmed febrile seizures. So now when we look at these patients and divide them into our 2 groups, our risk interval and our comparison interval, so again, comparing people who had a febrile seizure in the 0 to 1 days following vaccination to those people who had a febrile seizure in the 14 to 20 days following vaccination, we can see that more of these seizures occurred in the 12 to 23 month age group, as would be expected from the baseline rates. There's no significant differences by sex, race, or ethnicity, although this is a diverse population. So then further looking at these and their patients and their medical history, we'd see that for about half of these patients, this event represented their first ever seizure in their lifetime, which means that for half it did not. They had a previous history of seizure. We saw no differences between these 2 groups in family history of febrile seizure, history of premature birth, NICU admission or developmental delay, other potential risk factors for febrile seizure. Those people who had their seizure in the risk interval were slightly more likely to have received antipyretics in the week before their seizure, but they were not more likely to have received antibiotics. And then when we looked at whether people had other potential non-vaccine causes of fever documented at the time of their evaluation, and we found that the most common of these were otitis media, upper respiratory infection, viral syndrome. 37% of children in the risk interval had some other cause documented, compared to 77% of children in the comparison interval, which, again, sort of as expected, suggests that some of these seizures were influenced by their recent vaccination. But then looking in the last row, we see that whether or not people were admitted for the seizure, only about 1 in 10 were, and there was no difference by vaccine association. So now when looking at the vaccine exposures that these patients had, you can see in the first column all the different vaccines they were exposed to in descending order of frequency. So you can see PCV7, Hib, TIV, hepatitis A, DTaP are the most common vaccines. And then in the far right column, we see the crude relative risk, which does not take into account any confounding or interaction between different vaccines. So this just illustrates that if you look at any vaccine without taking into account confounding by other vaccines, you don't have a good true estimate of the risk. And that's what we want to delve into further. So now looking at the issue of combinations of different vaccines received on the same day, among these 333 people, there were 129 unique vaccine combinations received, again, considering each of those vaccines listed in the previous table as a separate vaccine type. So among these combinations, only 21 were received by 4 or more patients, which is to say that most combinations are, these unique combinations are not involved in a lot of cases. We can't look at each combination and estimate a risk for each different combination separately. So our approach to this, to delve into all those different vaccine exposures on the previous slide, is to use regression modeling. So we first examined 2 time periods separately, the earlier time period and then the 2010-11 flu season separately to see if there were differences. And then based on those results and those findings, we thought it was valid to pool all the study time together. And then our approach was to do multivariate modeling to identify vaccines associated with an increased risk of febrile seizure while accounting for confounding and effect modification between multiple vaccines received on the same day. So again, we started out by considering all those vaccines that were shown in the previous slide, and we used a manual backward elimination process to consider all of them and look for those that had some effect on febrile seizure, using TIV as our main effective interest. So I'm not showing all that iterative process by looking at a lot of different models, but basically the final result is the vaccines retained in the final multivariate model were TIV, PCV either 7 or 13, and the DTaP containing vaccines considered as a group. And so once we identified those vaccines using that process, we then went on to also look at those in stratified models defined by the mutually exclusive combinations of these 3 vaccines, which is what I'll show on the next slide to illustrate our findings. So again, now this is looking at the earlier time period, the 2006-7 through 2009-10 flu seasons. So again, looking at self-controlled risk interval analysis, we're now looking at the stratified results for these different mutually exclusive combinations of vaccines. So in the first strata, looking at TIV when given without those other 2 vaccines, we see there was no suggestion of increased risk of febrile seizure. So then when looking at PCV7, when given on a day without those other vaccines, we see the relative risk is 2, which is borderline significant, which is consistent with previous findings. So then when looking at DTaP-containing vaccines given without these other 2 vaccines, we do not see a suggestion of an increased relative risk. But then when looking at PCV given at the same time as DTaP, we see that the risk is very similar to when PCV is given alone. So then looking at when TIV is given with DTaP, now we're seeing an increased relative risk of 3.5, which is statistically significant. And then looking at when TIV is given on the same day as PCV7, we see a very similar result. And then when looking on days when people received all 3 vaccines together, we see the highest relative risk. So then replicating this analysis for the 2010-11 flu season on this slide, we'll see that we use the same approach, the same definitions for this strata. The difference being that by only looking at a single flu season, we have a smaller sample size, and none of our relative risks are statistically significant when restricted to the single flu season, but we see a very similar pattern. So on the next slide, just comparing the results for the 2 time periods, again, based on statistical testing and the similar trends, we felt that it was appropriate to pool our data for all the time periods together, seeing no differences, significant differences between the seasons. And then on the far right column, we see our pooled result of all the data from our study period pooled together, which we think is our best estimate of risk for these different vaccine combinations. So then the next slide, again, as we said, we wanted to extrapolate these relative risks into attributable risks, which is what is shown here. So in this slide, again, we have the same vaccine combinations, the same relative risks as showed from the pooled data on the previous slide, and we're showing the attributable risk estimate at ages 6 months, 12 months, and 15 months. And so the difference between the different ages is really the difference in background incidence of febrile seizure in the population. It's not a difference in relative risk due to vaccination. So we can see that in the far right column at the bottom row, our highest estimate of attributable risk is for the 3-way combination of these 3 vaccines given at 15 months of age, which gives us an estimate of 38 febrile seizure cases per 100,000 persons vaccinated with that combination of vaccines compared to the background rate or no vaccine. So in conclusion, the concomitant administration of TIV plus PCV or TIV plus DTaP-containing vaccines had higher risks of febrile seizure than when the vaccines were given independently. The concomitant administration of TIV plus PCV plus DTaP-containing vaccines had the highest relative risk. These increased risks with concomitant vaccination were observed in all influenza seasons studied, not just during the 2010-11 season. So that concludes. I'd like to acknowledge my colleagues in ISO, and then also our colleagues in the Vaccine Safety Datalink. It's more than 100 people, and I don't have space to list them all here, but they're very integral to these projects. And so at this point, I'll turn the podium over to our next speaker.
Good afternoon. Dr. Shimabukuro just gave an excellent overview of the history of studies on risk of febrile seizures following 2010-11 TIV. To go into a bit more detail, during the 2010-11 flu season, VSD investigators found a 2.4-fold increased risk of febrile seizures following TIV when adjusting for concomitant PCV13. Similarly, VSD investigators found a 2.5-fold increased risk of febrile seizures following PCV13 when adjusting for concomitant TIV. Furthermore, risk difference calculations suggested that there was a greater risk of febrile seizures with same-day TIV and PCV13 vaccination when compared to separate-day vaccination. However, a formal test of significance was not available at that time. Also relevant to the current results that I'm reporting on today are the VAERS findings, which were also mentioned earlier, where there was disproportional reporting of febrile seizures following 2010-11 flu zone. As a result of the VAERS findings, the FDA posted a notice on its website telling the public about the findings, and it also stated that that further investigation was underway. And as part of that investigation, we were funded by the FDA Centers for Biologic and Evaluation Research to conduct this current study. And we asked 2 study questions in this evaluation, both among children 6 to 59 months of age in the 2010-11 influenza season. First, we asked, was exposure to TIV or PCV13 associated with the greater risk for febrile seizures when compared to unexposed periods? Secondly, we asked, assuming children received both TIV and PCV13, did administering them on separate days, or administering them on the same day lead to a greater risk for febrile seizures when compared to separate days? And we examined these questions in the Post-Licensure Rapid Immunization Safety Monitoring System, or PRISM for short. PRISM is the vaccine safety component of the FDA-sponsored Mini-Sentinel pilot program, which was developed to conduct active surveillance for medical product safety. PRISM data partners currently consist of 5 health insurers. And in this study, we included data from 3 PRISM data partners participating at the time of the study, namely Aetna Healthcare and Humana. And we included children 6 to 59 months of age who were vaccinated between July 1, 2010 to June 30, 2011, where the 3 vaccines of interest were TIV and PCV13, and we also collected information on DTaP-containing vaccines to adjust for their confounding influence. And we used a self-controlled risk interval design like the one that Dr. Duffy just described for the VSD study, and we also used a 0 to 1 day risk interval, and for the control interval, we used 14 to 20 days. Exposures to vaccinations were identified in claims and immunization registry data. We also validated vaccination exposures in medical records if they were available. And following medical record review, we excluded cases that were later determined to have been exposed to LAIV or PCV7 according to the medical record. And outcomes were identified initially in claims data, also using a similar definition as Dr. Duffy described earlier. We use IC9 codes for seizures, simple febrile seizures, complex febrile seizures, or other seizures, and we included codes in the inpatient and ED settings only. We also validated febrile seizure status using medical record review. Each case was independently reviewed by 2 pediatrician adjudicators blinded to vaccination status. And febrile seizures were considered confirmed if there was a seizure and fever within 24 hours or a diagnosis of febrile seizure. We excluded those with conditions stated explicitly in the American Academy of Pediatric Treatment Guidelines for febrile seizures, and we also excluded focal seizures unless they were in association with a diagnosis of complex febrile seizure. We identified approximately 1.9 million children who were potentially eligible for this study, and of those, approximately 840,000 children received one of 3 vaccines of interest in this study, and of those, 252 were identified to have a potential febrile seizure event in the risk or control interval according to electronic data. And as I mentioned earlier, we conducted medical record review of potential febrile seizure cases identified in electronic data. And of the 252, approximately 85% had charts available to confirm febrile seizure status. 152 were confirmed for a positive predictive value of 70%. And of the 64 not confirmed, 19 were excluded because seizures were ruled out, 7 were deemed possible seizures without sufficient documentation, 8 were seizures without sufficient documentation of fever, 22 were afebrile seizures, and 8 were excluded due to other reasons. We also conducted medical record review of vaccines identified in claims and immunization registry data. And for the vast majority of vaccinations identified in electronic data, medical records were available. 79% of charts were available for TIV exposure, while 91% of charts were available for DTaP or PCV13 exposure. And when medical charts were available to confirm vaccinations, the confirmation rates were quite high. TIV or influenza vaccine was chart confirmed in 98% of cases, PCV13 or PCV was chart confirmed in 94% of cases, and finally DTaP was chart confirmed in all of the cases. Because the chart confirmation rate of vaccinations was so high, the analysis included both vaccines identified in electronic data or in medical records. And following medical record review, 5 cases were excluded because medical records indicated that the seizures occurred outside the risk or control intervals following vaccination, and a further 5 were excluded because LAIV or PCV7 was identified in the medical record. And here I'd like to take a moment to present the descriptive characteristics of these confirmed febrile seizure cases. As you can see, the vast majority occurred before 2 years of age, as expected. Most occurred in the ED setting without requiring hospitalization. And about a third experienced more than one vaccine of interest on the index date of vaccination, demonstrating the high rate of concomitant vaccination in the study, although I'll note that it's much lower than what was seen in the VSD. Next, we asked our first research question, namely, in the 2010-11 influenza season, was exposure to TIV or PCV13 associated with a greater risk for febrile seizures when compared to unexposed periods? And we did this by calculating relative risks and attributable risk estimates comparing exposed to unexposed periods. We estimated relative risks using a series of conditional Poisson models. The first were bivariate or unadjusted models. Then we adjusted for age and calendar time. And in our primary analysis, we adjusted for age, calendar time, and the 3 vaccines of interest. And for some more information on our age and calendar time adjustments, we determined the shape of the age and calendar time-based risk curves prior to including them in the age and calendar time adjusted models. And to do this, we included person time from the underlying PRISM cohort regardless of vaccination. Specifically, quadratic splines were used to adjust for age and also for calendar time. And here are our relative risk estimates. As you can see in the unadjusted analysis, each of the incidence rate ratios were above 1. PCV13 was statistically significantly associated with the risk of febrile seizures. When we further adjusted for age and calendar time, the results were similar. PCV13 was significantly associated with the risk of febrile seizures. And when we further adjusted for concomitant vaccines, the incidence rate ratios for TIV and PCV13 attenuated slightly. PCV13 was no longer statistically significantly associated with the risk of febrile seizures. And furthermore, the incidence rate ratio for DTaP attenuated greatly to 1.0 or to 1. I just described relative risk estimates. We also thought it important to quantify on the absolute scale any potential increase in risk following vaccination. And we did this by calculating attributable risks and by age and weeks, since the baseline rate of febrile seizures is known to vary pretty dramatically by age. The attributable risk was calculated as a function of the incidence rate ratios from the primary model, as well as the baseline rate of febrile seizure or seizures identified in claims data in the PRISM population, and we adjusted the baseline rate downwards using the positive predictive value of claims codes from this current evaluation. And then we multiplied that quantity by 2, the length of the risk interval in days, in order to get the attributable risk per dose rather than per person day. Some assumptions that we made when calculating attributable risks were that the incidence rate ratio was assumed to be constant across all ages. The baseline rate was based on the quadratic spline for age just described. And finally, the positive predictive value was based on chart review of control interval cases. And here are our attributable risk estimates. As you can see, each of the attributable risks, regardless of vaccination or age, were below 4 per 100,000 doses, with the highest attributable risk seen for PCV13, followed by TIV, and the attributable risk for DTaP was pretty negligible. The highest attributable risks were seen at 16 months of age, and the lowest attributable risks were seen at 59 months of age. We also calculated attributable risks based on the worst case scenario, and we did this by calculating the attributable risks that corresponded to the upper limit of the 95% confidence intervals for the relative risks. And under these assumptions, the attributable risks for TIV ranged from 0.93 to 7.1 per 100,000 doses. For PCV13, they range from 1.2 to 9.2 per 100,000 doses. We consider that these attributable risk estimates under the worst case scenario are quite modest in size, considering that the baseline risk of febrile seizure is approximately 2,700 per 100,000 children across a child's lifetime. We just addressed the question of whether TIV or PCV13 was associated with a greater risk for febrile seizures when compared to unexposed periods. Next, we asked a different question, specifically assuming children received both TIV and PCV13 in the 2010-11 influenza season, did administering them on the same day lead to a greater risk for febrile seizures when compared to separate days? And we did this by calculating the difference in attributable risk for same-day vaccination versus that for separate-day vaccination. Specifically, the attributable risks were based or translated from the incidence rate ratio estimates from the self-controlled risk interval design data that I just described earlier. And this cartoon here describes or depicts heuristically this concept of same-day versus separate-day TIV plus PCV13 vaccination. On the top is a hypothetical example of a child receiving TIV and PCV13 on the same day, whereas the bottom shows a hypothetical example of a child receiving TIV and PCV13 on separate days. And as you can see, the purple cylinder represents, in this hypothetical example, the attributable risk for same-day vaccination. We calculated the attributable risk for same-day vaccination based on the incidence rate ratio estimates from the conditional Poisson model that I described earlier. And in this hypothetical example, the attributable risk for separate day vaccination is represented by stacking the red cylinder on top of the blue cylinder. And we calculated the attributable risk for separate day vaccination by summing the attributable risk for TIV without concomitant PCV13 plus the attributable risk for PCV13 without concomitant TIV. We then assessed whether the attributable risk for same-day vaccination was equal to the attributable risk for separate-day vaccination. And to test whether there was meaningful differences between the attributable risk for same-day versus separate-day vaccination, we then subtracted the two attributable risks. And we also constructed 95% confidence intervals using Monte Carlo simulations. And when we did the analysis, we did not find any evidence to suggest that same-day TIV and PCV13 was associated with an excess risk of febrile seizures when compared to separate-day vaccination. In fact, the point estimate itself suggested 1.1 fewer febrile seizures per 100,000 children with same-day TIV plus PCV13 vaccination, although note the result was not statistically significant and the confidence interval quite wide. And now for the discussion. Before I make my conclusions, I thought it'd be important to lay the PRISM results in the context of the prior VSD results from the 2010-11 season. What you first might notice is that the incidence rate ratios are statistically significant in the VSD study, but they are not in the PRISM study. However, we consider these results between the two studies to be consistent for two reasons. First, the incidence rate ratio estimates are above 1 for both studies. And secondly, the confidence intervals overlap widely. However, the confidence intervals in the PRISM study are much narrower and the point estimates lower. We therefore think that the magnitude increased risk is probably lower than previously thought. Next, we compare the same-day versus separate-day vaccination of TIV plus PCV13 in the PRISM and the prior 2010-2011 VSD study. In the PRISM study results that I just presented, we found that same-day vaccination was associated with approximately 1.1 per 100,000 children fewer febrile seizures with same-day vaccination, while the VSD study found or suggested that there were 7.3 excess cases per 100,000 children vaccinated with same-day TIV and PCV13 vaccination. However, no statistical test was done. I'd also like to point out the strengths and limitations of this PRISM study. The strengths are that we use a self-controlled risk interval design which inherently adjusts for time constant factors or relatively time constant factors. We implemented a rigorous adjudication process of febrile seizure cases by 2 pediatricians blinded to vaccination status. And we implemented age, calendar time, and DTaP vaccine adjustments in our analytic models. And finally, perhaps our greatest strength is that we had 80% power to detect incidence rate ratios of the size of 2 or above. However, like any other observational study, this study was subject to limitations. First, we were unable to validate all vaccine exposures. However, when we did have medical charts available to confirm vaccination status, we confirmed them in over 90% of cases. And finally, we were limited in power to detect incidence rate ratios below the size of 2. However, this is the largest study to date on 2010-11 TIV and risk of febrile seizures in the US population and results in the narrowest confidence intervals to date. And finally, for my conclusions, we conclude that in the 2010-11 season, the incidence rate ratio point estimates for TIV and PCV13 were above 1. However, TIV, DTaP, and PCV13 were not significantly associated with febrile seizures in the primary analytic models. We can't rule out the presence of increased risk for TIV and PCV13. However, if they existed, we conclude that the magnitude of the incidence rate ratios is lower than originally thought, as well we conclude that any potential increase on the absolute scale would be quite modest in size, and we say this because the attributable risks based on the upper bound of the 95% confidence intervals for the incidence rate ratio suggest this. And finally, we conclude that assuming that children receive both TIV and PCV13 in the 2010-11 season, administering both vaccines on the same day was not significantly associated with a greater risk for febrile seizures when compared to separate day vaccination. And finally, I'd like to take a moment to acknowledge my many collaborators at FDA, the data partners, the Mini-Sentinel PRISM team at Harvard, as well as the clinical adjudicators. Thank you.
So I want to thank Dr. Duffy and Dr. Kwai for two excellent presentations. I also want to thank all the CDC and FDA staff and the staff at our partner organizations who have investigated this issue over the past 4 years. So what I'm going to do now is summarize this information for you, and I'm going to do that through a series of Q&A slides. So, was the overall risk of febrile seizure increased with the 2010-2011 formulation of TIV? And evidence from published studies includes the VAERS signal in 2010-2011 for Fluzone, the VSD rapid cycle analysis signal in 2010-2011, and the VSD study looking at concomitant TIV and PCV13, which found that elevated risk for febrile seizures in children peaking in 16 months with 45 additional febrile seizures per 100,000 children vaccinated. The persistence of the VSD rapid cycle analysis signal for TIV during 2011-2012, and the CISA study that found a threefold higher rate of fever on days 0 to 1 when TIV and PCV13 were given together as opposed to separately. The above studies could not adequately distinguish the independent risk of febrile seizure associated with TIV alone versus risk with concomitant vaccinations. So what was the independent effect of TIV on the risk of febrile seizures? The PRISM analysis found no statistically significant independent increased risk of febrile seizure associated with TIV during the 2010-2011 influenza season. You saw the relative risk of 1.4 with the non-significant confidence interval, and this was an adjusted analysis, TIV adjusted for PCV13 and DTaP. The updated VSD analysis found no statistically significant independent increased risk for febrile seizure associated with TIV during the 2010-2011 influenza season, a relative risk of 1.2. In a stratified analysis, and this was TIV given without PCV13 or DTaP. And the updated VSD analysis found no independent increased risk of febrile seizure for TIV given without PCV or DTaP during the 2006 through 2009 influenza seasons. So was the risk of febrile seizure greater when TIV was given with PCV and or DTaP? The updated VSD analysis for the 2010-2011 season suggests that the relative risk increased about threefold when TIV was given with PCV and or DTaP compared with unexposed periods. And similar results were seen for the 2006 to 2009 influenza seasons. The PRISM analysis did not find any greater risk for febrile seizures for same-day versus separate-day vaccination with TIV and PCV13 during the 2010-2011 influenza season. So the weight of the evidence and the consistency of the findings from the VSD analysis over several seasons suggests that when TIV is given alone, risk of febrile seizure is not increased. When TIV is given with PCV and or DTaP, however, the risk of febrile seizure is increased. The highest risk is when TIV, PCV, and DTaP are given together at 15 months of age. The attributable risk was 38 additional febrile seizures per 100,000 children vaccinated with that combination. And this is similar to the febrile seizure risk seen with MMR vaccine. So to conclude, simultaneous administration of TIV with PCV and or DTaP vaccines appears to be associated with an increased risk for febrile seizures in young children. This increased risk is transient, the day of to the day after vaccination, and although frightening for parents and caregivers, febrile seizures do not have lasting effects. Getting recommended childhood vaccines during a single healthcare visit has important benefits. On-time vaccinations keep children protected against many infectious diseases, and providing multiple vaccinations in a healthcare visit minimizes the number of healthcare visits that parents, caregivers, and children must make. I'd like to acknowledge the following individuals for helping with this presentation. And at this time, I'm going to invite Dr. Duffy and Dr. Kwai up to the stage, and we'll take questions on the presentations.
Dr. Rungold.
So I want to thank you for the elegant presentations. I do have a technical question, and then I have a comment about the overall interpretation. The technical question is, I'm interested that the comparison, the control interval you chose is after the risk interval rather than before. And I wonder if you've done the same analyses using the comparison interval being before rather than after the risk interval, and if it makes any difference.
So that risk interval was chosen specifically to sort of exclude the risk period for MMR and MMRV vaccines. So other methods have, used like self-control case series used before and after person time. I think our goal in this analysis, we did not specifically use pre-vaccination person time, but our goal was to replicate the original findings so that they would be as closely comparable to the surveillance that was done in 2010-11, which used those same risk intervals.
Sorry, I'm not sure that's the answer to my question. My question is, if you choose the control interval before rather than after the risk interval, does it make any difference?
Well, I mean, we don't think it should, but we haven't looked at it.
I'm just curious because it seems to me if, for example, something touches off a seizure, maybe during the several weeks after that, you're at a lower risk of a seizure. So I'm not quite sure why you choose the comparison period being after rather than before. So I'd be curious if you do the analysis a different way. But my comment is sort of the issue of the PRISM analysis showing that there's basically, which is what I would have expected, that when you basically look at the combined risk of giving the vaccines separately, there's basically no greater risk of giving them together on the same day when you look at the attributable risk, which is what I would have expected. It seems to me that's somewhat at odds with your conclusion that the relative risk of giving them together on the same day is increased. How can you exclude the possibility that each of the individual vaccines given separately has perhaps a 50% increase in relative risk, a relative risk of 1.5, which your studies don't have the power to exclude, and that in point of fact, the overall risk is no different giving them combined on the same day as opposed to giving them separately on individual days?
I'm not entirely sure I understand the question. In our study, we did examine whether same-day TIV and PCV13 was associated with a greater risk for febrile seizures, and we did not find any difference. And for our relative risk estimates, we wanted to isolate the independent effect of each of the 3 vaccines, which is why we don't present the joint effects of TIV and PCV13 in relative risk format.
Going back to the conclusion slide from before this one, or the 2 slides before. About the simultaneous administration being associated with an increased risk of febrile seizures.
If we could pull up my second slide set. Let's see. So you're talking about the attributable risks, and your question is about comparing the attributable risk between the different combinations?
Well, I guess I don't want to belabor the point.
Right.
My point is that if giving one vaccine on one day has a relative risk of 1.5, which you can't exclude with your confidence intervals, then perhaps the risk of giving the vaccines individually on separate days, overall, there's no greater relative risk than giving them all together on one day.
Right, okay. So we did test that in the multivariate model. And so again, using a multivariate model that included all 3 vaccines in the same model, we did test for effect modification. So you can see here on this slide the p result values for those tests of for difference by concomitant vaccination. So you can see that the TIV-PCV interaction is almost 0.05, a little less. The TIV-DTaP interaction is more statistically significant, and the 3-way interaction is 0.07. So it is, tending towards significance, but not significant. But I would argue that this suggests that there is a difference in relative risks for the 2-way combinations, at least, and a suggested interaction for the 3-way combinations that are different than giving them on separate days or the independent effects of the vaccines.
Are there other questions or comments? Yes, Dr. Gorman.
This is a question for Dr. Kwai, and it has to do with the model. So I suspect I'm going to see this model again, so I'd like to understand it. You said you used a Poisson modeling. Are you
Yes.
talking about a Poisson distribution around the lambda as the model?
I'm using a conditional Poisson model.
All right. And the second question is, when you talk about quadratic smoothing or quadratic splining, my understanding of Poisson is that that's a logarithmic function and not a quadratic, or is that just a terminology issue that's changed in the 30 years since I looked at this last?
We did use a Poisson function. We used quadratic splines. Could you repeat the question, please? I'm not entirely sure I followed.
So in the dark ages, when we talked about Poisson modeling, we talked about log linear, and you talked about quadratics. So I was wondering if there was a difference in the terminology or whether there's been a difference in the interpretation of how you do the math. Thank you. Okay.
I don't know, maybe I can jump in and try to help out. I think maybe the quadratic spline was for the age effect. It wasn't for the relative risk. They were just trying to model, right, exactly. Is that right?
Oh, thank you. Yes, that's correct. I use a quadratic spline for the age and calendar week effects, not the effects of vaccination.
Thank you.
Dr. Plotkin.
This is probably a question for the AAP representatives, but what is the recommendation concerning the use of antipyretics for TIV? Or are there such recommendations?
The recent recommendations is that the AAP is not supportive of using prophylactic antipyretics, but they are very comfortable with using antipyretics for children who have developed fever.
So is there any possibility of re-examining that in the light of the data suggesting that TIV, together with other vaccines, increases the risk?
I think that because of the concerns of the safety of the antipyretics in that age group, I think that you would have to kind of balance the risks of the antipyretics versus the risks of the febrile seizures. And my guess is it would come out pretty much a wash. And given this data that suggests that there's only a very, very slight increase, you'd be giving an awful lot of children antipyretics to prevent very, very few. Also, I don't think there's a lot of good data to suggest that using antipyretics prophylactically actually does reduce febrile seizures. So I think that we would probably currently stand on the recommendation is that for prophylaxis of fever, we would not recommend, but if a child does get a fever, we have no problem with treating.
I'm wondering if Dr. Broder has a response there. I see you moving up to the microphone and know that you have some background here.
This is Karen Broder in the Immunization Safety Office. I just wanted to let the committee know that we do have some pilot work going on with the CISA project through Duke University and CDC, and we're just exploring the effect of using prophylactic antipyretics versus placebo on immune responses after an inactivated influenza vaccine. The work is just beginning, but I think these data over the next year or two might be informative, at least to speak to the issue of whether you blunt immune responses with antipyretics. And I believe that's the concern out of previous literature, that you would potentially blunt immune responses after these vaccines, and you may not see the protective efficacy. Thank you.
Hi, this is Grace Lee. I'm short, so I'm going to take this. Just wanted to add some additional comments in responses to the questions that were raised. So it's a great question. I think Dr. Reingold raised the question about why not a pre-control interval versus a post-post. And we've always just traditionally done that because of the healthy vaccinee effect. And you could argue in this instance it probably would have been okay because of the short time interval, and it probably made no difference either way. But we didn't do that in this particular instance. In terms of the second question that you raised, I think the answer is that both interpretations are correct, but they answer slightly different questions. One being the 2 vaccines in an exposed period compared to an unexposed period. And yes, if you give 2 vaccines, I think then, there's more risk of fever, and potentially that puts you at risk for a higher risk for febrile seizures. But when you're talking about the assumption that children will receive vaccines and whether or not there's a greater risk for same day versus separate day, at least in the PRISM study, we believe that there is no greater risk giving them on the same day, assuming that you're going to vaccinate your kids anyway. And then we didn't have the method available in the prior VSD study to be able to provide confidence intervals. It looked elevated. It may have been that those confidence intervals were wide in the first place, and we could not say either way. And then there was one other question that was raised was the quadratic spline. It was specifically because there's so much time varying confounding by age, and it's by week of age, that we felt the need to actually adjust for that in the offset term. But it was a conditional Poisson.
Thank you much. Other questions? Dr. England.
Janet England, Pitt. I just wanted to know if the investigators took into account virus vaccination analysis. Recent paper 2013 showing the protective association of virus rotavirus like cause 2 children using use for all incidents of has gone down. Done by I would just ask change in time.
Well, right. So, I mean, there's a couple different questions there. One is sort of like, I think, addressing the cumulative risk over time. So we're, again, just looking at transient risk during the post-vaccination period. So this study or this data wouldn't address the more cumulative effect over, a child's lifetime of how many febrile seizures they might have by being vaccinated versus unvaccinated with particular vaccines. But again, looking at just the specific 0 to 1 day risk interval post-vaccination, which, just looking at the other vaccines, we did look at all the vaccines that these children received, and no other vaccines besides the 3 we've been talking about seem to have any independent effect once you control for the effects of the others. So again, we didn't have data on monovalent rotavirus vaccine, but on the pentavalent rotavirus vaccine, there's no suggestion of an independent risk of febrile seizure in that 0 to 1 day period.
Any other questions, comment? Okay, thank you very much for the presentations. And also, looks as though we are on time for Dr. Coyne Beasley. We'll introduce the topic on adult immunization.
It gives me great pleasure to introduce the adult immunization session. Once we get the slides up, the first slide will actually be acknowledgement of our work group. And I am internally grateful for this work group who works really, really hard. And in fact, our work group has sub-work group committees that you'll hear about as well. I'd like to acknowledge our ACIP members, our ex officio members, our CDC lead, Dr. Carolyn Bridges, who has worked tirelessly to make sure that the work can get done for this group. Also our liaison representatives and consultants. I would also like to acknowledge Dr. David Kim, who will actually be transitioning into the CDC lead role for this particular work group. And collectively, would also like to acknowledge Dr. Kim, Dr. Bridges, and our consultants, LJ Tan, as well as Diane Peterson, for all the work that they did not only on the work group, but for the development of our annual National Adult Immunization and Influenza Summit. So if I can go to our third slide, I'd just like to summarize some of the key activities that we've had. Those include actually publishing our recommendations in the Annals of Internal Medicine in February. As routinely, standardly done, this was approved by the American College of Physicians, as well as the American Academy of Family Physicians, the American College of Obstetrics and Gynecologists, as well as the American College of Nurse Midwives. It also was published in the MMWR, and the differences between those two publications is that the MMWR publication highlighted the changes from the previous years, and it did not include figures in the contraindications tables. Since that time, there have been many communications documents done by many individuals at the CDC, and the CDC has also updated the adult and adolescent immunization quiz in February. I'd like to thank those individuals who will be providing presentations today. On the next slide, we will be welcoming again Dr. Walter Williams, who has graciously agreed to come again and provide a summary of recently published non-influenza vaccine coverage among adults. And Dr. Chris Shahidi will provide an update describing the CDC immunization campaigns. And then I will come back and close out with some of the activities that we've done to address lagging coverage in adults. Dr. Williams.
Thank you. System. Okay, thank you. There we go. This presentation summarizes results from the 2012 National Health Interview Survey that was published in the MMWR in February of this year. I will describe the data source, provide a very top-level summary of adult coverage by age, race, ethnicity, and vaccination target criteria, some brief limitations, conclusions, and provide sources for additional information. The NHIS is an annual in-home survey of the health and health status of non-institutionalized civilians in the United States, conducted in the homes of those individuals. It's done annually. Questions about receipt of adult vaccinations is asked of a randomly selected adult in each family of each household. Weighted data were used to provide national coverage estimates. The final response rate was 61% for the 2012 NHIS. The sample size was just over 34,000. This report does not include influenza. It does include pneumococcal vaccination. Overall, that includes the polysaccharide as well as the conjugate vaccine, tetanus toxoid-containing vaccines, including TD and Tdap, hepatitis A, hepatitis B, zoster, and HPV vaccination. The proportion of pneumococcal vaccination by type of vaccine was not measured in the 2012 NHIS. And Tdap vaccination of adults was collected for the first time in the 2012 NHIS on adults 65 and older, and analysis was done on that group. Comprehensive information on high-risk status was not collected in the NHIS, 2012 NHIS, so there's limited information on Hep A and Hep B. For Hep A, travel status and chronic liver disease. For Hep B, diabetes mellitus. High-risk conditions for pneumococcal vaccination are shown on the next slide. We did collect information on healthcare personnel, including those who provided direct patient care. The definition of high risk for pneumococcal disease were those adults who had been told by a doctor or other healthcare professional they had any of the conditions, selected conditions listed here, or were current smokers. Looking at some of the coverage estimates, again, the pneumococcal estimates are overall estimates for both the polysaccharide and conjugate vaccines. For high-risk individuals, 19 to 64 years, coverage was 20%. For those 65 and older, 60%. Among adults 60 years and older, 20% reported receiving herpes zoster vaccine, and that represented a 4.4 percentage point increase compared to estimates from 2011, and that was primarily due to increases that occurred among non-Hispanic whites. Looking at tetanus vaccination during the previous 10 years, the proportion of adults who received tetanus vaccination during that period was 64% for adults 19 to 64 years, as well as those 50 to 64 years. TD vaccination for adults 65 and older was 55%. Looking at adults 19 to 64 years who received Tdap, during the past 7 years. The estimate was 16%, representing a 3.2 percentage point increase compared to 2011. And again, that increase was primarily due to increases in non-Hispanic whites. For persons living in a household with an infant less than 1 year of age, Tdap vaccination was 26%, and this was similar to the estimate for 2011. Among healthcare personnel aged 19 to 64 years, Tdap vaccination was 33%, and this was a 5.8 percentage point increase compared to 2011. 34% of respondents were excluded from estimations of Tdap coverage, creating a potential for bias. The Tdap coverage was estimated after excluding those without a yes or no response to tetanus vaccination during the past 10 years, those without a response to tetanus vaccination during the period 2005 to 2012, those who reported tetanus vaccination but either were not told or did not know the vaccine type. We conducted a sensitivity analysis to assess the magnitude of potential bias that might result from these exclusions. And depending on what proportion of excluded respondents actually received Tdap, actual Tdap coverage could fall within the range of 11 to 31% for 11 to 39% for adults 19 to 64 years, and 6 to 31% for adults 65 and older. And this sensitivity analysis assumes no errors in reporting when the responses are all yes or no combinations. Looking at the proportion of adults who received Tdap among those who received any tetanus vaccination, among adults 19 and older who received a tetanus vaccination during the period 2005 to 2012, 53% either were not told, another 11% could not recall the vaccination that they received. Of the remaining persons who received tetanus vaccination in that group, 65% reported receiving Tdap. Among healthcare personnel, 33% were not told, another 9% could not recall. And among the remaining healthcare personnel, 76% reported receiving Tdap. Vaccination of healthcare personnel for Tdap was statistically higher than that among non-healthcare personnel. Looking at hepatitis A, B, hepatitis A coverage remained low at 12% for persons 19 to 49 years old, and this estimate was similar to that of 2011. Hep A coverage was higher among those who had traveled outside the United States to an endemic area at 19% compared to those who had no endemic area travel at 9%. Hepatitis B coverage among healthcare personnel 19 and older was 65%, and this estimate was similar to that from 2011. Hep B coverage among persons 19 to 49% was 35%. 19 to 49 years, rather, was 35%, and this estimate was similar to 2011. Among persons with diabetes, hepatitis B vaccination was similar to estimates from 2011, highlighting the need to increase awareness of the higher risk for acute hepatitis B in that group and the need for vaccination. Looking at HPV vaccination, among women aged 19 to 26 years, 35% reported receiving at least one dose of HPV vaccine. And this represented a 5 percentage point increase compared to 2011. And again, this increase was primarily due to increases in non-Hispanic whites. Coverage among women 19 to 21 years was 44%. Among women 22 to 26 years, it was 28%, and this was a 6.7 percentage point increase compared to 2011. The increase among women 22 to 26 years indicated that some catch-up vaccination is occurring in this age group, primarily among white women. We did not collect data on age of vaccination in 2012, so could not determine whether vaccination of younger women, such as age 19 to 21, occurred as part of an adolescent program or when they were 19 or older. We are collecting data on age of vaccination in the 2013 NHIS. Coverage among males has remained low since the ACIP recommendation to vaccinate males in October of 2011. This just summarizes the increases that I described to you for 3 vaccines that have been more recently recommended for adults. The range of increases is from 3% to 5 percentage points. The increases in HPV, TD, Tdap, and zoster vaccination were due, again, primarily to increases among non-Hispanic white women, indicating, and non-Hispanic whites overall, indicating a widening gap in coverage compared with non-Hispanic blacks, Hispanics, and non-Hispanic Asians. The increase, the difference or disparity that we see in HPV vaccination of women is not seen when we look at data from the National Immunization Survey among teens. We are looking at that in greater detail and comparing cohorts vaccinated in NHIS versus NIS. And when comparing the results, overall, we have similar overall results when we compare HPV coverage among persons who are 17-year-old in NIS teen data and 18-year-old in NHIS data, except that there were substantial differences for Hispanics that may actually indicate a large bias in the NHIS self-reported data for HPV vaccination among women. This graphic summarizes all of the disparities that we're seeing in this analysis. It shows the vaccination groups for which we reported results by race, ethnicity, the vaccination coverage among non-Hispanic whites, and the difference in coverage for non-Hispanic blacks, Hispanics, and non-Hispanic Asians compared to whites. And all of the significant findings are in bolded red or blue. And shown in red, we see that there were statistically significant disparities for 31 of the 42 comparisons by vaccine and age target groups. And these disparities range from a -2 percentage points for Hispanics versus whites in Hep A in 19 to 49-year-old adults to a -27% for Asians versus whites for HPV vaccination in 19 to 26-year-old women. There was only one instance with higher coverage than whites, and that was Asians having Hep A coverage 7 percentage points higher than whites for the age group 19 to 49 years. So to summarize the racial and ethnic disparities shown in this report, compared with 2011, differences persisted for all 6 of the vaccines and widened for Tdap, herpes zoster, and HPV. Non-Hispanic blacks and non-Hispanic Asians generally had lower vaccination coverage than non-Hispanic whites for all of the vaccines that are routinely recommended for adults, with the exceptions listed here. Among healthcare personnel, non-Hispanic black and Hispanic healthcare personnel had lower coverage for Tdap, but similar coverage to whites for Hep B. The report had several limitations. The NHIS excludes people in the military and people residing in institutions, so the results apply only to the civilian non-institutionalized population. The response rate of 61% is low and can result in sampling bias if non-response is unequal among participants regarding vaccination. Self-report of vaccination and health status in the NHIS was not validated by review of medical records, so there is potential for recall bias. Self-reported vaccination has been shown, however, to be sensitive for all of the vaccines in the report and specific for all of the vaccinations except tetanus vaccination. It's important to note that the accuracy of recall by young adults of vaccinations routinely recommended during adolescence has not been studied. Tdap estimates, again, there was a potential for bias due to the exclusions. And again, age of vaccination is not known for vaccines reported as ever received, so it's unclear if vaccination occurred as a young adult or as part of a child or adolescent vaccination program. So in conclusion, overall, for the 3 vaccines in healthy people 2010, that's the pneumococcal vaccine, zoster, and Hep B for healthcare personnel, overall coverage remains low and far below the healthy people 2020 targets for those vaccines. Despite some improvements from 2011, vaccination overall for adults still remains low. Racial and ethnic disparities remain, which leaves us with quite a bit of work to do to increase utilization. I want to acknowledge the collaborators on this report. Dr. Lori Markowitz also collaborated on this report, but was inadvertently left off this collaborator graphic. Additional information on all of the ACIP recommendations for the specific vaccines in this report are at the URL shown there. and the non-influenza adult vaccination coverage report is at that URL. Thank you.
Hi, good evening. So it's my pleasure to have the opportunity to update you on CDC's communication activities related to adult immunization. Okay. Oh, got it. Okay. Great. I'll provide a brief overview of our program as well as highlight for you some of our communication activities and the new resources that we've made available. In the fall of 2012, we launched a 2-year adult immunization communication program. Our broad goal was to develop a brand as well as messages and materials that could help raise awareness and promote immunization according to the recommended schedule by targeting both adults and the physicians and other healthcare professionals that serve them. Knowing that making changes in social norms and behaviors related to adult immunization requires a long-term effort well beyond our 2-year project timeline, we set out to lay a strong foundation for this and future work through formative communication research. Our research included a national survey, which I shared with you last year, focus groups with adults, as well as a review of available published and gray literature related to adult immunization communication. In addition, we were able to conduct 28 in-depth interviews with physicians and nurse practitioners and registered nurses. The topics we discussed with them are listed here and include the vaccine conversations they have with their patients, as well as the recommendation process. We do have summaries of this research available for those who are interested in more details. Based on our research, best practices, and a number of helpful behavior change models and theories, we developed a framework for how communication efforts can encourage adults to get vaccinated. I won't go into details. The bottom line is behavior change is complicated. On the right side, as we all know, are the different stages that people may go through in terms of vaccine decision-making. On the other side, you can see the different strategies that can be helpful in moving people through those changes. In the middle are some of the key factors that mediate those, and we know that all of this is very important to be delivered by the most trusted source, and those are doctors and other healthcare professionals. Thus, the green arrow going through all of the stages. There are some key drivers in our framework and approach to communicating with adults about immunization. They include stressing the relevance and importance of timely vaccination by highlighting susceptibility and explaining the severity and potential costs of getting vaccine-preventable diseases. However, this information has to be balanced with empowering messages that present vaccination as a doable step that can be taken to protect themselves and their loved ones. We also need to provide plain language information that can help adults make informed decisions and provide support in getting vaccinated. And our information should be as tailored as much as possible. For our communication to the public, we do encourage adults to talk with their doctor or other healthcare provider to get tailored recommendation information. Key principles of our communication with healthcare providers include reminding them why vaccination is an important preventive measure and their role in making sure their patients are protected. The recently updated NVAC standards provide guidelines that call on all healthcare providers to take certain steps, including sharing a strong recommendation. So it'll be important to share what we've learned from consumer research regarding what can make recommendations compelling and how to best address patient questions and concerns. In our most recent research with healthcare professionals, not all physicians responded positively to our information about the standards, in some cases feeling that it's not realistic for us to ask them to assess vaccination status and discuss needed vaccines at every visit, for instance, when they're dealing with a patient who's got an acute issue. A critical piece of what we focused on is the conversation between providers and their patients. For some patients, a clear, strong recommendation that a vaccine is needed may be sufficient. Others may want additional information. So we've summarized the 5 main best practices we identified for strengthening vaccination recommendations into an approach we call SHARE. While there's no magic message or script that can work across all adult vaccines and for all patients, we believe that these are important communication strategies that providers should keep in mind when helping patients make the decision to get recommended vaccines. We've developed a variety of communication resources that can be used with a broad general audience of adults, as well as those with chronic conditions. These include outreach products like posters, flyers, web buttons, and mat articles, as well as materials that can be used for patient education, including fact sheets, and tools to assist adults, such as our online quiz and our revamped website. Here's just a few samples of some of our media and outreach products. We have also developed communication products, resources, and tools to encourage and support healthcare providers in improving adult immunization practices, as we know they are so critical in getting adults vaccinated. One thing that isn't on the slide but's worth mentioning is that we launched our vaccine schedule app last month, and in its first 20 days of being available, it's been downloaded 3,600 times, and that does include the adult immunization schedule. So our materials for healthcare providers does include a series of fact sheets on improving adult immunization practice, including vaccine assessment, recommendation, administration, referral, and documentation. Each sheet covers one of the steps and provides tips, resources, and tools to aid in implementation. The second sheet in the series includes the SHARE approach, as well as some tips on how to address common questions. And we continue to look for opportunities to get the word out broadly about adult immunization, and we had the opportunity to do that in February with the release of the data that Walter just presented. Some of our activities are listed here. And our next big push or outreach effort will be during National Immunization Awareness Month, and we look forward to working with partners to try to get the word out about adult immunization during that month. So next steps for us include continuing to share our key research findings with our partners and health communication professionals, continue to test and develop patient educational materials and other healthcare professional resources, including in Spanish, as well as to disseminate our messages, products, and resources through the engagement of partners and media. And of course, as flu season is approaching, we'll look for opportunities to promote adult immunizations as we're encouraging people to get their annual flu vaccination. As always, we ask partners to use our products in a number of different ways and to feel free to give us your input and feedback. She's not listed on this slide, so I have to say a special thanks to Aparna Ramakrishnan. This is her slide deck, and if she were here, she'd be presenting this for us. And she's done so much of the heavy lifting on this program that we have to just call her out especially. But also thanks to others who've been involved. And of course, at any time, if you have questions, requests, or input, you can send that to me or to Aparna.
Thank you to our presenters. I'm just going to present a little bit about some of the key activities that are going on with this work group to address lagging coverage in adults. I want to highlight one of our primary activities, which is the National Adult Influenza Immunization Summit. And this summit is a partnership of 300 organizations whose goals are to convene adult influenza immunization key stakeholders, but not just to convene as a group, but to actually leave that summit with actions that can be taken by the members to improve the uptake of our ACIP adult recommended vaccines and improve uptake of influenza vaccine among all ages. As I mentioned, this is an annual conference that takes place. Our last conference was actually in May, and it was held in Atlanta. But our work groups, in fact, meet year-round, and these were some of the subgroups I referred to. There are actually 5 work groups that are dedicated to issues related to providers, patient education, access and collaboration, quality, and decision makers. I'd like to just present a few of the highlights from the meeting. Some of our highlights included presentations by Dr. Howard Koh, Dr. Tom Frieden, and a very creative and innovative presentation from Dr. Ann Schuckett, which helped us to think creatively and innovatively about ways we could vaccinate adults in even creative locations. We also had some preliminary data presented to us from an investigator at the University of Colorado who noted that, in fact, there is limited knowledge among providers regarding issues of billing and payment for adult immunizations. And likewise, there's also limited use of immunization systems by many of our adult medical providers. What we also learned, which we see with with adolescents and childhood immunizations as well, is that there was evidence to suggest that patients are actually willing to get vaccinated if they receive a strong recommendation from their adult provider. Some other meeting highlights included presentations and discussions of the challenges of developing quality measures for adult immunizations, but we also presented many examples of success in raising coverage where practice standards for adult immunizations were applied. I really would like to refer you to the website that you see here because many of these success stories can actually be found in the presentations contained within these websites. We also heard from manufacturers that regarding the doses that are expected to be available for influenza, we do not believe that we'll have any supply-related issues. As I mentioned, one of the key things is not just convening all these key stakeholders, but actually leaving the meetings with action-oriented plans that we intend to do the year after this program. And I just want to share a couple of those with you. The members have committed to exploring a CPT code for vaccine counseling, to promote implementation of standards of practice for adult immunizations, to actually increasing awareness of adult immunizations through multiple venues, but in particular through the National Immunization Awareness Month that you've just heard about. And we also want to identify and disseminate provider business tools to reduce practice costs as a barrier for providers. We want this to be a winning proposition, not just for our patients, but also for our providers and their offices. And then we also want to continue the evaluation of adult immunization quality measures. And finally, address any barriers that are related to in-network provider status requirements that occur not only for our patients, but also for many of our providers. I'd now like to actually call Dr. Williams and Dr. Sheedy back up to the podium so that we can address any questions that might exist.
Thank you very much for the presentation. Dr. Dushan?
Thank you for that discussion of really important work. One question I have, in our practice, local public health, we deal with healthcare providers around immunization issues and find that one of the barriers is perception of the time investment that's needed by the provider to do the kinds of things that we're asking them to do around counseling and explaining the risk and the benefits, the burden of disease, the occupational risk, some of the things you described. So I guess I had two questions. One is, are you looking at, how much time it takes a provider to implement the types of recommendations that you've developed here in the practice setting, so we can tell them? I think it's very important for them to have a realistic expectation of how much time this will take. We're asking them to. And the second question is, more and more patients are being managed by medical teams as opposed to individual providers. Mm-hmm. And those teams have specialists that deal with specific aspects of the patient's health, chronic disease and whatever. And I'm wondering if you've explored potential to have immunization be a part of the team medicine approach in those facilities that use the team approach and how that might work.
Yeah. So thank you for that question. I happen to be a member of the provider work group, and so a lot of those issues are actually being discussed by the provider work group. And to talk about specifically the very first question you asked is how much time it takes and really how involved that is. That really is one of the main reasons why we're looking into the development of a CPT code. So not only can we evaluate how much time it takes, but so that physicians can also be reimbursed for that time. And as it relates to the second part of that question, that's something that we're discussing. And my particular work group actually meets monthly and more frequently when we need to, but we will certainly take that under advisement and are really considering that as well. Carolyn, did you want to add anything additional to that? Okay. And I should also acknowledge Susan Farrell, who actually is our leader of our work group and who does a fantastic, tremendous job, not only for this sub-work group, but also was heavily engaged in the summit as well.
Dr. Bennett.
I just wanted to build on what Dr. Dushin said. Thank you for that great but very discouraging presentation. You know, we've been discussing adult immunization for so many years and have struggled for so long, and it is kind of discouraging. And I think a couple of things just to build on what Dr. Dushin was saying. One is that there has been a lot of work done at looking very granularly at what it takes to immunize adults in practices. John Fontanesi, who is at UC San Diego, used to study this in great detail. There's a lot of interesting information in his work. The second thing is that we did come to the conclusion, I think, years ago, that really the only way to push this. Oh.
Can you turn the volume, maybe?
Sorry. Can you hear me now? No. Okay. Now? Can you hear me now? No. Got pretty close. I could swallow it. Okay. I'm sorry. So just on the second point about using Teams, and now I'm blowing out Art's ears. I think that is a really critical point. And I think that, many years ago we established in our own community that using extenders of professionals was really the best approach, most cost-effective and most efficient. I think that, all of this also, we are in an era where this can all be automated to a large extent. And so we really want to look for solutions that make this part of the way providers do business and their offices do business through automation, use of extended team, and standing orders. Let's not forget standing orders. They're very, very helpful in this setting.
Dr. Kemp? No.
Thank you. Just to respond a little bit to what Jeff said as well, in our national surveys of internists and family medicine providers, one of the biggest time sinks, of course, is figuring out what people need and not having the information to do that. And I just want to, in a general way, having spent my career doing implementation of delivery in pediatric practices, I think we can learn a lot from each other. And since pediatrics is largely, a big part of pediatrics is delivering immunizations, I hope that we can learn lessons from one another. One of the biggest plugs I want to put in for is for systems, because behavior change is very difficult, but the low-hanging fruit really is much easier, and the majority of adults as parents of children are not vaccine hesitant or resistant. They simply don't know they need it, and they're not there at the right time. So immunization registries, which now exist in every state, can right now start having adult records, and in fact many states do, can provide a forecasting function at the point of care, can forecast what patients need, can automatically generate reminder recalls for entire populations, and the efficiency there is just huge. And I think that, getting from 20 to 60 could be pretty quick, honestly, if systems like that were implemented. And then you have to get into the communication that takes a long time with patients that are hesitant or worried. But the low-hanging fruit to me is the systems issues.
I'd like to just pick up on that point very quickly. And for AFP and for ACP, and I do have Ms. Hayes, Dr. Riley, and Dr. Evan in queue here. But for, I just went through my recertification process this year for AFP. The maintenance of certification is kind of a dirty word, I think, for internists, from what I understand, of a petition going around, yet it's something we're required to do every 7 to 10 years. And part of that is a quality improvement project, and I think if CDC were to partner with the professional societies in terms of creating a low-hanging fruit, easy to do. When I had to do my quality project, I picked an immunization. And what it does is it gets somebody in the habit of doing a assessment, very easy to do, a reminder recall. And those are things that for AFP, we have somewhere around 9,000 family docs every year having to recertify. I'm not sure how many internists, but I'm sure it's more than that. But that's one of those methodologies out there that I think we could slowly turn the tide. And once you start looking at your own data and start realizing how your reality compares to your internal estimation, it can be kind of shocking sometimes. So let me, Ms. Hayes?
I think I can do it on this one. I have it pretty loud. You don't think so? Okay.
The American College of Nurse Midwives was recently funded through CDC and ASTO to work on a communications project, and we had a lot of fun. I have to say it was just a blast. And one of the things that we developed was super women that have the most amazing graphics, and they have shields with bacteria and viruses coming at them. And this is all downloadable for free on our website because it was funded through CDC, so we would like to thank you so much. And the posters are giant and gorgeous, and they are available for shipping cost only. So if you go to midwife.org, immunization recommendations, it's just a lot of beautiful stuff.
Dr. Riley?
For a long time, ACOG has known that getting obstetrician gynecologists on board with the immunization campaign has been difficult, and we've known for a long time that it's the business aspect of starting an immunization program within the office has been a stumbling block. So ACOG actually did team up with AAP, as Dr. Kemp suggested. We did team up with AAP, and there is a webinar that is coming close to you on Wednesday, July 30th, from noon to 1, and it's entitled The Immunization Business and Clinical Strategies for OBGYN Practices. So basically, it's obstetrician gynecologists learning from what pediatricians have been doing for years and doing very well. So you can get more information about it on the ACOG website, immunizationforwomen.org, and anybody's welcome. The intended audience is really OBGYNs, but it could be any practitioner because it's starting the immunization practice within your office.
And if you can pass the microphone to your right.
Hi, Susan Even, American College Health Association. We have adopted that idea that an institution is a really good way to get college students up to date on their immunizations, and just took the American College Health Association has a document that just says, here are all the recommended adult immunizations for college students, and we keep it up to date based on what's the changes with ACIP. And as a practitioner and a director of a health center, my challenge has been not the interest in our providers, but the complexity of and I think that's where a registry would be fabulous. We have one in Missouri, and if we give an immunization, our electronic record will dump it into the state registry. But students come to us from all over the country, and they fax us and send us their million different appearances, documentation records, and we have only a few that are actually required.
So we pay attention to those. But then, when the student comes to us for a visit, we're trying to increase the familiarity both of the nurses and of the providers to say, okay, this is a chance. Have you had your Tdap? Because we kind of know the ones that are a little bit low-hanging fruit. But I think again, it's probably the documentation component and a registry would be helpful, and just that the students themselves don't really know, and they count on this piece of paper that their parents hopefully sent us. So we do have a way to go, and our providers are really interested in trying to move it forward.
And Dr. Jenkins.
One question I had to Dr. Williams was whether there was any analysis by income level, because it seems to me if there are disparities by ethnicity, there may be linked to disparities by income. And I think the issue of practices that serve low-income populations is another challenge for what Tamara is working on in terms of the business model, because pediatricians will tell you setting up to do immunizations is incredibly expensive in terms of the equipment, the type of monitoring you have to have in order to manage immunizations. And so, 2 points. One, do we know anything about the income differentials? And two, for Tamara, whether the provider group is really looking at sort of practices that may need some incentives in order to be able to set up for immunizations.
Thank you very much for your question. For this particular report, we basically looked at those covariates that I referenced at the start of the presentation: age, high-risk status, and vaccination target group criteria. We have done specific analyses on individual vaccines where we looked at other demographic and access to care characteristics like education, whether or not a person had a regular doctor, whether they had health insurance, types of insurance. And where those types of analyses have been done, consistently we see a risk for lower vaccination among those who have lower education, who don't have a regular doctor, who don't have health insurance, who make less money. So your point is well taken.
I think that the question that you asked in regards to the providers and what we're looking at the provider work group, I think the question is really interesting for a number of reasons. We've talked about immunization registries, and in fact, we know from the slide that I presented to you earlier that adults completely underutilize the immunization registry. But your question actually even points to an even larger issue. It's like we assume that everyone even has an electronic health record. And so when you look at the diversity of providers and who they serve, and even just the resources that people have within their offices, there's a wide range. And so to try to meet that need, one of the things that's really important to us in the provider work group is that we actually have a diversity of providers as members of those work groups to help us figure out kind of what are the needs that you particularly have. And I also appreciate the conversation about teams, because really that's how vaccination programs can be done most efficiently and successfully in offices. And so we don't mean to imply at all that the work is going to be easy, but getting a diversity of opinions, a diversity of practices, who have a wide variety of resources is going to be really important in trying to combat this issue. Immunization registries are really, really important, and so are even things like electronic health records and accessing them, their practices without internet access.
Gentleman up the microphone, please.
Yes, I'm Mel Cohn from Merck Vaccines. Thank you very much for very thought-provoking presentations. One kind of data I didn't see in your presentations, however, were data about the rates of immunization among healthcare providers. And I wonder if it's really realistic to expect that providers are going to carry the messages we want them to carry if they're not getting vaccinated themselves. We know even in the setting of an H1N1 pandemic, it was really a challenge. So I wondered if any of you had any thoughts about that and what kinds of activities we might engage in that area to improve adult immunization rates.
There were at least 2 data points provided for healthcare personnel in the presentation on coverage, one for Tdap and one for hepatitis B vaccination, although they were mentioned very rapidly. in that top level summary. And you're quite correct that our experience has been when healthcare providers themselves serve as models, as well as offering strong recommendations in their practices for their clients, that vaccination levels in those types of practices are much higher than when that circumstance is not the case.
Dr. Freihofer.
Sandra Freihofer, American College of Physicians. I can't let the family medicines one-up us. The internists do have a QI project that you can get MOC credit for. The American College of Physicians also has an ACP Connect, and what we're trying to do is find joy and quality improvement so we can also share in the joy of knowing our patients are vaccinated. So.
Thank you for that update. Another comment back here at the microphone.
Bob Hopkins from Emergent Biosolutions. I'm not sure if this is a comment or a question, but I've always wondered whether it's possible to implement something like a personal vaccine record rather than like an electronic medical record or personal medical record, something that would just be very specific to vaccines so that you sort of empower the patient. Maybe give it to the obstetrician to, to start from birth, and then it would go all the way through. So like something that you would have an app, most people can put in your contact list, So the question is, can people enter themselves vaccines, and could they get reminded? Could they get sent reminders? So sort of skirt the healthcare professional altogether and go right to the mom, and then carry that forward from to teenage, college, and further. Has that been considered?
Yeah, so it's a very provocative comment and or question. And in fact, I see this more kind of in pediatrics than in adults. But, this happens quite frequently in non-industrialized countries. And I happen to do a lot of mission work. And one of the things that's really interesting to me is that oftentimes there isn't an electronic health record. There isn't even an immunization registry. But somehow built into some of the cultures in countries where I've worked that are non-industrialized, they carry around a health record with them in the way that we carry around a purse or the way we might carry our wallet. And it's entered into that particular health record whenever they see a healthcare provider. And so I could be in some of the low-wealth communities that actually have high immunization population-based data for their populations, but yet don't have some of the advances that we have. So I do believe that there is the opportunity to empower families and empower patients, empower adults to keep their own records. We did this a lot in pediatrics, certainly many years ago, where everyone had your AAP guide where you stamped in what their records are. And so I think that that is a great alternative in addition to trying to do some of the automation that we're talking about.
We do have a public comment here by a Dr. William Schaffner. I believe that might be you up at the microphone.
Okay. Excuse me.
Thanks very much, John.
Dr. Keating wanted to respond.
I was just going to make a comment on the app, but I hate to cut off Dr. Schaffner. I think the comment about an app is also really worth thinking about. I imagine that some of the issues that sort of texting systems like Text for Babies came up against would apply, where we'd be hard-pressed to get adults to download an app that was only about immunization. But if it's sort of wrapped up in the different things they need at the different stages of their lives, and immunization was a part of that, I think that'd be much more likely to be something that folks would put on their iPads or iPhones. So I appreciate the comments.
So thanks, John. This is Bill Schaffner, and I'm standing on behalf of my friends at the Gerontological Society of America. The Gerontological Society of America, GSA, is pleased to present this statement on behalf of its initiative, the National Adult Vaccination Program, NAVP, which is a multi-stakeholder, industry-supported collaboration to improve adult vaccinations aligned with the recommendations of the CDC's Advisory Committee on Immunization Practices. The members of the Gerontological Society of America include researchers, practitioners, educators, economists, health policy experts, and others interested in expanding scientific knowledge across the lifespan, making it a natural home for the NAVP. The National Adult Vaccination Program promotes that immunizations continue to be one of the greatest public health success stories. Additionally, NAVP, along with this committee, clearly recognizes that vaccine-preventable diseases disproportionately affect older adults. With this in mind, on behalf of GSA's NAVP, we look forward to joining with the ACIP as you continue to consider the need for strong vaccine recommendations that include the unique challenges of older adults and the need to protect them from preventable diseases through vaccines. Thank you.
Thank you for the comment. Turn over to Dr. Gellin.
Just briefly, I'm going to steal a minute out of the NVPO update for tomorrow because of this topic. As Tamara mentioned, Dr. Coe spoke actually many times at the Adult Summit, has made adult immunizations a priority for him. He asked for the development of an adult immunization strategic plan, which is in development. So you'll see that when it comes. So I wanted you to know that was coming. Also, HHS has been working with the National Quality Forum to develop performance measures. Those are out in draft, so you should take a look at those and comment, because this is the time to do that. And then there's a webinar that's scheduled for next week as well, but all related to improving the systems for adult immunizations. Thanks.
Thank you much. Is there further comment, question? Okay, well, thanks to the Adult Immunization Group for the presentation, and I think we stand closed for the day. Thank you so much.